Good morning, everyone, and I'm excited to welcome you all to our final Wednesday presentation of our 2021 Arrupe Series. And welcome back if you have joined us for one of our previous sessions. We are going to begin today as we begin all good things in prayer. So let us begin in the name of the Father, and of the Son, and of the Holy Spirit. Amen. So as we conclude our Arrupe series today, we will say the personal prayer of Pedro Arrupe. This was a prayer that he said as he was Superior General of the Jesuits. Grant me, O Lord, to see everything now with new eyes, to discern and test the spirits that help me read the signs of the times, to relish the things that are yours, and to communicate them to others. Give me the clarity of understanding that you gave Saint Ignatius. And so we pray this morning for the grace to be attentive and to listen, to see and hear with the eyes and ears of Christ. And as we conclude our reflections today, we pray that we may go forth with the freshness to re-examine our world so as to better understand, love, and serve one another. Amen. Saint Ignatius of Loyola, pray for us. Saint Peter, pray for us. So once again, welcome to our 2021 Arrupe series. This series is usually a week-long summit on faith and justice, but this year, our 24th year of the series, it's spanning the entire month of March. So this event is named for Pedro Arrupe, the 28th Superior General of the Jesuits, who really charged the Jesuits with their modern mission of forming men and women for and with others. This year, we focus on public health. As we all know, the COVID-19 pandemic has highlighted many economic, social, medical, and educational inequalities in the United States and around the world. And as a Catholic school, we will examine how our faith understands public health as a universal right and understands the ways in which people of goodwill are responding to this pandemic. So for our final speaker, we welcome Dr. Amesh Adalja. Dr. Adalja is a senior scholar at the Johns Hopkins Center for Health Security, and his work is primarily focused on emerging infectious disease, pandemic preparedness, and biosecurity. Dr. Adalja has served on U.S. government panels tasked with developing guidelines for the treatment of plague, botulism, and anthrax in mass casualty settings, and for the system of care for infectious disease emergencies. He also served as an external advisor to the New York City Health and Hospitals Emergency Management for Highly Infectious Disease Training Program, and has served on a U.S. FEMA working group on nuclear disaster recovery. He is also the spokesperson for the Infectious Disease Society of America. And specifically during this COVID-19 pandemic, Dr. Adalja has served as a member of the NCAA Coronavirus Advisory Group, as a consultant to various businesses, schools, and organizations, and as an informal advisor to the International Monetary Fund. So we are excited to welcome him to our virtual campus today. So please give your full attention and respect to Dr. Adalja.
Thank you for that introduction. Thank you for inviting me to speak. I think I really enjoy speaking to high school students and other students rather than sometimes the stiff government panels that I'm speaking to, where I can be a little bit more informal and more myself when I'm talking about something I think is really important. And I went to a Catholic school from K through 8, so this is already looking at seeing a priest with the white collar is bringing back memories, mostly good. So what I want to do in this talk is kind of give you an overview of what's happened during this pandemic and where I think it's going and what it means for the future when we think about pandemics. And I spend all my time working on pandemics. I was this kid who was very interested in pandemics from a very early age, liking infectious disease stories and the battles between infectious diseases and people. And I really specialized in a very niche part of infectious disease. And it's very strange when something that you specialize in, that's people think that you're an esoteric, weird person that likes these pandemics, becomes the biggest thing in the world. And that's why I'm here. It was because I spent some time thinking about this for basically alone and with a group of people that I work with. And it's a lesson to you that even if you've got some interests that are not necessarily things that are in the mainstream, they can become very important to the world. So it's important just to pursue things that you like. Just because I'm talking to a high school audience, I wanted to say that. So I'm going to start with first talking about how this pandemic started and why it spread around the world so quickly. So when you think about all the infectious disease threats that you might hear about, so for example, Ebola or rabies or anthrax, there are only certain ones that have the ability to spread around the world. And when you look at them, there's a couple of characteristics that I think are really important. One is they have to be contagious. Not every infectious disease is contagious. So if I had tetanus, you can't give tetanus to somebody else. Tetanus comes from the environment. It's not communicable or passable between a person to a person. So that's necessary. Then it has to be able to do it easily, meaning that it can't be something that's hard to get from one person to another person. So since it's a Catholic school, I will give you a biblical reference. Leprosy is all through the Bible. It's not that contagious. It's very hard to spread leprosy from person to person, even though people thought that. So that's not something that can cause a worldwide pandemic. So you need it to be easily transmissible. And what's the easiest way to transmit something? Why am I doing this virtually? And I'm not in the same room as you. It's because if something spreads through talking, laughing, coughing, breathing, that makes it very easy to get from a person to a person. You can't stop it that easily. If something is spread through sanitation, so something like typhoid fever, you can clean up your cities. You can have people have home sanitation. You can use chlorine. You can do all kinds of things to fix that. But when it's something that's talking, breathing, there's not much you can do except for get people to stay apart from each other or wear a mask. And we all know how hard that is. So back in December of 2019, when we had when China had reported a new respiratory virus there that came from a viral family called coronaviruses, and most of you probably never heard of coronaviruses before. It set off alarm bells because, first of all, we know coronaviruses are respiratory viruses, meaning they spread from person to person through respiratory droplets. And this is actually the 7th human coronavirus that's discovered. And 4 of those coronaviruses cause 25% of our common cold. So all of you have had a coronavirus. It's just that most of those coronaviruses don't have the ability to cause serious disease, to cause you to be hospitalized, or to cause you to die. So that rang alarm bells. And that was coupled to the fact that there had been some very serious coronavirus outbreaks with other coronaviruses, one called SARS in 2003, which you're all too young to remember. I don't even know if you were born then. In 2003, I have to do the math in my head. But that was a coronavirus that circled the globe, 8,000 cases, killed about 10% of people who got infected. It was a worldwide calamity. And it put coronaviruses on the map as a potential infectious disease emergency. Fast forward about 10 years later, another coronavirus called Middle East Respiratory Syndrome also appeared, this time in the Arabian Peninsula, places like Jordan, places like Saudi Arabia, Qatar. This is spread from camels to humans. And it again was something that had a very high mortality rate. About 30% of people who were infected died. So people were worried about coronaviruses. But when we initially saw this one, the initial report was this wasn't transmitting efficiently from human to humans. Like it was more like the SARS and MERS than the common cold causing coronaviruses. So there wasn't initially an alarm, a big alarm. Some countries did sound an alarm like Taiwan, and they've done excellent because of that. But soon after, in January, we realized that this wasn't just animal to human, that there was sustained human to human transmission going on. So in January, we had the data to know that this was going to be something that was going to spread through the human population. And because there was no population immunity, because the other coronavirus, the immunity you get from the common cold causing coronaviruses wasn't enough. We didn't have any coronavirus vaccines. We didn't have any coronavirus antivirals, that this was going to engulf the world. And indeed, if you look, the first cases were reported in December of 2019 in China. But if you look back, there were cases that were actually discovered in November. There were cases already in France in December. The virus was found in the sewage in Italy in December. So this virus, by the time we even knew about it, had already left China. It was already everywhere. So that's one of the lessons, that this was not going to be a containable virus. So what do you do then if you have a non-containable virus? You don't just throw your hands up. You basically prepare by making sure that you have, for example, that your hospitals are ready to take care of cases, that they have enough personal protective equipment. We also already knew that the people that were really vulnerable to severe disease were those who were elderly. So you fortify your nursing homes to make sure that this virus stays out of nursing homes and that nursing homes have adequate supplies to be able to take care of patients there and to recognize it. And I think the most important thing is you have to test. You've got to get testing set up. And that's why the U.S. had such a bad problem. I think, using another biblical analogy, this is the original sin of the pandemic, that we did not have testing, and we still don't have great testing. So if you remember back in January, February, March of last year, you could only test people that had come from China. But I told you already, this had already gone from China, and we all knew that. And you could only test people that had lower respiratory tract symptoms. So people that had coughs or shortness of breath. You couldn't test somebody with a sore throat. You couldn't test somebody that just had loss of taste or smell. So what we were doing is not testing people that were contagious, even though we knew it was COVID-19, and just basically putting them back on the street. So very predictably, what happened was this virus started transmitting. These chains of transmission started that were unrecognized until they hit vulnerable populations, until those people needed to be hospitalized. And that's what we saw. We had these bubbles in places like New York City and in New Jersey and in Seattle, where you really saw the result of kind of our inaction. So that's how it became such a worldwide pandemic. If you are proactive with a pandemic, so a country like Taiwan, I think, is the only one you can say that. They jumped into action on December 31st, 2019. They had 8 deaths. They didn't have to use lockdowns. They're not reliant on a vaccine because they were able to control it by using the tried and true principles of public health: test, trace, and isolate. But again, in the United States, our public health departments are decimated. They're not valued. They're not something that are any part of any politician's reelection campaign. Think about the last time you had a county executive or what you have in New Jersey, county commissioner elections. How often do they tout their health department? Probably never. It's not something they consider really important. And it goes, and public health goes through these cycles of boom and bust. When something is in the headlines like Ebola or anthrax or Zika, you see some funding go, funding go their way. But then when it recedes from the headlines, it all disappears. But those people are still left there at the public health departments with outdated technology, under-resourced, having to do all the contact tracing for things that you don't see. When you think about all these infectious diseases that are in the United States, we have over 10,000 cases of tuberculosis every year in the United States, but none of you worry about it. It's because public health is actually intervening early and doing contact tracing, finding those patients and linking them to treatment. But you don't think about it, so it's not valued. And I think that's also something that allowed this pandemic to spread throughout the country very quickly, because our public health departments were not able to keep up. They don't have the resources. And you didn't have governors that were actually willing to do it. So that's why we had that surge in the summer. That's why we had that surge in the winter, because we didn't build the public health infrastructures to keep cases to a manageable level. We didn't develop the ability to test. So when you look at the US's trajectory in this pandemic, it's really a completely predictable thing based on everything that many of us in the field have been saying basically to deaf ears for decades and decades, writing report after report, which is likely gathering dust in some desk drawer. So it didn't have to be this way. And the point is, when you deal with a respiratory virus like that, you have to be aggressive. You have to be proactive to avoid all of the consequences we have. And part of those consequences are the cascading impacts of what happened when governors issued stay-at-home orders and closed non-essential businesses, because that's going to have a lasting impact on everybody's life. We are going to pay for that in the long run. But most politicians really only care about the short run, and they didn't think about a sustainable approach. And that's what we have to get right. And I'll talk about that at the end, a little bit about how to get it right. The second topic is, what somebody wanted me to talk about, what the future of COVID is going to be. So where are we now in the United States? I think we're in a pretty good place compared to where we have been. Right now in the United States, we still have over 50,000 cases occurring per day. And that's an underestimate. We know not everybody is getting tested. But what's really important is that we've been able to change the trajectory of this pandemic through the use of this vaccine. So these vaccines are extremely life-changing, extremely important. And the reason why is because they stop three things. They stop the ability of COVID-19 to cause serious illness, hospitalization, and death, meaning that they will never be able to threaten hospital capacity again, that these viruses are going to be defanged or tamed. Remember, flattening the curve was really about keeping cases to a manageable level below hospital capacity. And that's what these vaccines are doing. So eventually what we're going to see in the United States is the decoupling of cases. So meaning we're not going to pay so much attention to cases. We're going to be looking more at hospitalizations. And indeed, hospitalizations are falling in almost all parts of this country. Now around 36,000 people are hospitalized. It had been over 100,000 a few months ago. So we are getting better. And what is that the result of? It's the result of where we're putting the vaccine. We're putting the vaccine into people who are at high risk for hospitalization, nursing home residents, community dwelling high risk individuals. So that's changing this virus, removing its ability to cause all those severe consequences that brought it to our attention in the first place. And I think that's where we're going to go. And I think you're looking at Europe right now, and that's a place where people are very nervous. They're talking about all these lockdowns happening. And the reason that Europe is in a different position than us is because they cannot vaccinate fast enough. We're putting 2 to 3 million doses of vaccine into people's arms every day. To me, that's not fast enough. We need to go faster, but it's a lot better than what's going on in Europe. And what that will hopefully do is stave off the complications that could occur from, for example, these new variants that you hear about, the UK variant, the Brazilian variant, the South African variant, because the vaccines are excellent at preventing what matters: severe disease, hospitalization, and death. So the solution to the variants is to be vigilant, especially when you're unvaccinated, to make sure that you're behaving responsibly, but also to accelerate vaccination with no speed limit. Just get vaccine into people's arms and we will avoid that. And I think we're on the way to doing that, because looking at the numbers, looking at what rounding in the hospital every week, I see a change, and I hope that this is sustainable, but it's really dependent upon the vaccines. But remember, we're not going to get to COVID zero. It's not going to be as if this gets back into the bottle. This virus is going to be with us. It's going to be something that causes sporadic outbreaks. You'll hear about it in several, you'll hear about it years from now, but it's not going to be something that you see, for example, putting people in hospital. You're not going to see people dying from it at the rates that we see. So it's going to become one of our normal respiratory viruses, like influenza, like RSV, if you've heard of that, or all the other viruses that cause bronchitis and cold and flu-like symptoms. Because we're going to change it because of the vaccine. It's not going to be something that is as serious, and that's going to change the public perception of this disease. And you will start to see things open up, things get back to normal, even before we cross herd immunity. Because once this virus isn't able to kill at the rate that it is, it's going to change how people think about it, and that's a good thing. So it's not going. So don't be fooled into thinking we're going to get to COVID zero. That's not possible. We're going to have to incorporate this into our daily lives, but it's going to be a much more manageable virus as we get our vulnerable populations vaccinated. And speaking of vaccines, I was also asked to talk about children getting vaccinated. So a couple of things to think about. Right now, the Pfizer vaccine, if you're 16 or 17 years old, you can be vaccinated with the Pfizer vaccine. It is approved for that. And some states like Alaska, Mississippi, they are vaccinating 16 and 17-year-olds. But the question about childhood vaccination for COVID-19 it's a little bit bigger. Remember, anytime you get a vaccine, there's a risk-benefit ratio. There's the risk of the disease you get, the benefit from the vaccine. There's also the risk from the vaccine, and that's a calculation you have to you have to undertake every time you think about a vaccine. So, very different to vaccinate a 71-year-old against COVID-19 versus a 7-year-old. Because the risk of a 71-year-old contracting a severe case of COVID-19 is astronomically higher than a 7-year-old getting a severe case. So there's a difference there. The other issue is that children are not magnifiers of COVID-19 in the community, meaning they don't spread it all around the way they spread influenza, for example. So there was less of a priority placed on childhood vaccination. I do think that COVID-19, there are benefits in children because there are some children who get severe disease. There are some severe complications like multi-inflammatory syndrome that children can get. So this is something that we're studying right now. There are clinical trials going on in older children and younger children. It's going to take some weeks to months before we get that data. But I think it's important that we do those studies because of the different risks and benefits that a child may have. And it's not one of these first generation vaccines that children get. Maybe it will be a second generation vaccine that gets developed a couple of months down the road or a couple of years down the road, but we'll see. But I do expect children will be vaccinated at some time. I think the priority though should be if we're looking at children, the priority should be vaccinating high school children because high school children do have a lot of the characteristics of adults. They also are the ones that are more likely to spread it. And they also participate in lots of extracurricular activities like sports, which a vaccine can make a lot easier to do. So the third thing I was going to talk about here is when do we get back to normalcy? So I think that's a hard question because every infectious disease emergency changes the society in which it occurs. So if you go back and read about the Black Death that happened in medieval Europe in the 1300s, so many people died that it basically overthrew the entire feudal system, which you might be learning about in history class. It led to the peasants' revolt. Because so many people died that now these peasants had so much power and the landlords lost a lot of power because so many people were dead that they were able to basically create the middle class. I do think that this pandemic is going to change us. We will get back to some semblance of normalcy, but there's certain things that are going to be different. So for example, think about how we're doing this on Zoom, I'm not there in person. Imagine how that's going to change the world. So you might have, your parents might tell you that I have to fly to Chicago for this Friday morning meeting every Friday. And their company may say, we're not paying for that anymore because you can do it on Zoom and it's just as productive. So that might change. So people may do a lot more telecommuting, a lot more of this because this technology, Zoom and all of its competitors have really increased their capacity to do this. Do everything virtually without having to be in person. So that might be something that you see a lot more of. I had never ordered Uber Eats before the pandemic. That's going to be something that people stick with, that they're going to be getting used to it. All these people that were holdouts that decided, I'm going to start buying things on Amazon. I'm going to use Uber Eats or DoorDash. That's going to change our behavior. And what's that going to do? Sadly, I'm somebody from the 1980s. That's going to kill our beloved shopping malls that were on the verge of dying anyway. I spent most of my high school years in a shopping mall at the arcade and places like that. So I've got fond memories. Those were already dying. I think many of them are going to die. There still probably will be luxury malls, but the whole mall rat culture may disappear because there won't be any malls for us to hang out in. People are going to change their vacation plans. They may be less interested in going to crowded, congregated places. And surely because our vaccine rollout is going to be different in different countries, different timelines, international travel is going to be something that's difficult. There are going to be places where this virus rages on until 2022 or longer. And that's going to be hard for people to go to. There may be vaccine certificates needed like we need for yellow fever. So that's going to change things. There are going to be people, even after mask mandates end in the states that have them, people are going to be comfortable wearing masks because they see the benefit of it, especially in crowded and congregated places, especially in public transportation, for example, not just for COVID-19, but for other respiratory viruses as well. Everybody asks where flu went. Flu went away because we social distanced and we wore masks. That's why this flu season was uncharacteristically mild, even though we were really worried about a twindemic. And I think that some people are going to say, well, I might as well just continue to wear these masks. The masks are getting better. They're getting more breathable. There are lots of improvements for masks for the general public. So that might be something that you see become more common in the United States. Just like if you've ever been to Japan or China or Taiwan, you see people wearing masks regularly when they're on the subway or in the airport. That might be something that becomes a little bit of a part of our culture. I don't think everybody will do it. I don't think it's necessary that everybody do it, but I think you probably will see some people be more wary of doing it. You're not going to be coming to school sick anymore. Lots of people who are sick are probably not going to want you. If you're sick, they're not going to want you around. That whole idea of presentism showing up. I'm the kid who showed up at 8th grade with chickenpox, but I had both parents were doctors, and they said, "This is just chickenpox. You can go to school." I got sent home pretty quickly, and my parents got called irresponsible. But that's a lesson. If you're a child of physicians, you are never sick enough to not do something. So that's going to go away. But I do think we're going to, are we going to have normalcy? Meaning, are we going to have stadiums full of people? Are we going to have Taylor Swift concerts? Yes. Is Broadway going to open again? Yes. All of that's going to happen. I think what we're looking at, though, is probably into the summer. And the big key for this is going to be having enough people vaccinated that we don't have to worry about it. There may be still some requirements for masks. There may be some temperature checks. There may be people who they may do things for vaccinated people only, like we're seeing happen in Israel. But I do think as we get into summer and more people get vaccinated, we will get there. The states are going to do this on their own, though. Each state is different. So if you're in Florida right now, it is pretty much normal. Movie theaters I'm in Pennsylvania. Movie theaters, I think, are opening on the 4th of April. So we are starting to see that benefit. And what is that tied to? Exactly what I said before, hospital capacity. If hospitals are not inundated, then I think governors have a lot more flexibility. So I do think we will get to normalcy. I think that there's been a lot of people really realizing that some of these short-term gains versus the long-term consequences, that trade-off is a very hard one to make. That we know that children suffered for not having in-person schooling. We know that childhood vaccinations against other diseases went down. We know cancer screening went down. We know that mental illness went up, substance abuse went up. All of that is something, those were longer term consequences that many of these policymakers just didn't think about. And hopefully that's something that's going to influence their decision making, because we can't do this forever. We have to get out of this false dichotomy where it's not Mardi Gras every day, but it's also not a Wuhan style China lockdown forever. That we have to use this path, and that's what the vaccine is about. So I think that's the important thing to remember about the vaccine. What do I think about, what do we do in the future now in terms of, and this is the last topic before I take questions, about the future? Is this predictable? Can we think what's happening, what's going to happen to the next pandemic? So I think it's important to remember, it's not a question of if we're going to have another pandemic or if we're going to have another infectious disease emergency. It's when is it going to happen? Because there are many viruses, many pathogens out there that have pandemic potential. So for example, in China, there are certain bird flu viruses, there are certain swine flu viruses that we really track and worry about. And there are programs in place in order to do this, to study them, to look and see which ones have the characteristics to cause an infectious disease emergency, to cause an epidemic or a pandemic. Which ones are behaving differently, getting the ability to infect humans more efficiently, to spread between humans. And the only way that we know that is through surveillance, through actually funding this as kind of a national security concern, to making sure that this is something we do all the time, that it's not something that goes through cycles of panic and neglect, that we have the ability to look at what's happening all around the world with viruses. And remember, it's not always going to be some exotic location where a virus emerges. Remember the last pandemic we had, the 2009 H1N1 influenza pandemic, which was not a very severe pandemic in terms of death. It arose from Mexico in North America, on our own continent. So we have to be thinking about these infectious disease threats everywhere. And one of the things I think is important is just to get much better at diagnosing things. So how many times, I know you're all high school students, so you probably don't go to the doctor that often, but how many times has your pediatrician said, you've got a virus, you've got some virus, just take some Tylenol, take some ibuprofen, you'll get better. That I think has to go away. We have to understand what virus it is, because many of those respiratory viruses that can cause common colds or bronchitis, they also might be able to cause serious illness. Indeed, COVID-19 is one that does that. Most people, if you got COVID-19, one of you in the audience, a 16-year-old kid, most likely it's no different than any cold that you had for most people. But it will be really important to know that this is a new coronavirus causing common colds, because that might be something that has pandemic potential. So we have to get better at diagnosing this. We have to also, as I said earlier, fortify our public health departments. They need to be resourced, not just to work on kind of the flashy things that are in the headlines, like childhood obesity or pollution or restaurant inspections, but also to be thinking about infectious disease threats, to make sure they have contact tracers, that make sure they have new technology, that they can hire people very quickly. That's really important as well. Hospitals also have to get better at thinking about emergency preparedness. They don't think about it because it doesn't pay them to think about it. We've got to get some more redundancy in the system so that they're not caught flat-footed, that they're not running at capacity. In our health system, it's very advantageous for a hospital to be like a hotel, always full. An empty bed means they lose revenue. So they shut down those beds. We have to find some way to be able to augment hospital capacity, to be able to make hospital capacity something that can be expanded. I talked about Zoom earlier, what we're talking on this platform. Zoom during this pandemic expanded. Hospital capacity is almost like a fixed quantity. You can expand it a little bit, but not that great. So we've got to get better at that as well. We really just have to be proactive. This has to be something that you should talk to your congressman, or your congresswoman or congressman about, talk to your governor about, write letters, state reps, state senators, to your county governments to make sure that your county health department is funded adequately. You have to actually be an advocate for public health. We cannot let this happen again. And you have to think about this as being a government failure. The federal government failed us, the state government failed us, our local governments failed us. It's really been a cascade from the top down on why the pandemic affected us this way. So we have to get this right. And there is a window of opportunity to do that. So you've got to talk to people about this as a priority, because all of our lives were disrupted by this. Over 500,000 people died in this country. So many more got infected. We're going to have massive cascading impacts after this pandemic. But all of it could have been different if we were proactive, if this was something valued, if we acted like Taiwan and not the way we did. So I think that's what I would say, that this is something that can be prevented. So that's all my formal comments. I hope that was interesting to you and that gave you something to think about. And I'm happy to take questions in the remaining time. Thanks again for your attention.
Thank you so much. Okay, we have some prepared questions. So I'm going to hand it over to Mr. Aaron Saunders.
Just first off, I want to say absolutely amazing, really informative, and I just want to thank you for that. I do have some prepared questions, but I do see some in the Q&A that do reflect some of these if you want to do those as well, just because some of them reflect the prepared questions.
I defer to you. You can just read them off. You can read them, or you want me to read them off, or?
If you don't mind, Aaron, if you want to read your questions first, since
Absolutely.
they are also, we collected them from students. So you do those first, and then we have enough time, we can do the Q&A questions too.
All right. So the first one, which you touched on specifically, was how does this current pandemic compare to previous epidemics? And then how are they also different? So just like the similarities and then the differences as compared to polio and the Spanish flu, the swine flu, and SARS.
All right. So I would say, in the 20th century, this is as severe as it's not quite as severe as the 1918 pandemic, but it's on that scale. So the 1918 influenza pandemic probably killed 50 million people around the world. It did kill around 700,000 Americans. So we are approaching that in terms of 1918. SARS is a little bit different. SARS only killed about 800 people. It didn't really kill anybody in the United States. There's only a handful of cases here. And that's because SARS was something that wasn't transmitted efficiently from person to person, something I mentioned earlier, that SARS could infect people, but it really wasn't able to transmit this way. It wasn't efficient. So SARS was the first warning shot, though, that coronaviruses could cause major problems. But this is nothing. This is much more worse in terms of its scope than SARS. Although on a pound for pound basis, SARS was a more deadly virus in terms of if you got infected, if you want to be infected with SARS or SARS-2, the virus here is called SARS coronavirus 2. That causes COVID-19, you want to be infected with this one versus the first one, because the first one had about a 10% mortality rate. This mortality rate is about 0.5%. It's just so much more transmissible. More people got infected. That's why the death toll was higher. Polio is very different. So polio is something, that plagued our ancestors in the 1940s and before. And this was something that for most people was a mild GI illness, kind of a gastroenteritis that you would get. But in about 1 in 100 or even less than that, you could get paralysis with polio. And it was something that flared every summer in the 1940s in the United States. So this was also polio is an interesting story because it is something that only happened when we got more industrialized and more hygienic. Because if you were a small child and you got polio when you were a baby or when you're 1 or 2, when you're outside eating dirt and all the other bad stuff you did, that wasn't going to be a very serious illness to you. It's only when American and European children got cleaner, meaning that they weren't exposed to dirt and germs so much as at a younger age. If they got it maybe around age 7, 8, 9, that's when they had a more likelihood of developing paralysis. And that's why it became such an emergency, which led to a major vaccine effort, not by government, not like Operation Warp Speed, but by the March of Dimes. And that led to the successful development of 2 polio vaccines. And that controlled it very, very well. And I think, one lesson from polio that I like to, and the polio vaccine, I'm talking to you from Pittsburgh, Pennsylvania. It was made in Pittsburgh, Pennsylvania by Jonas Salk. was that this vaccine was celebrated. There were ticker tape parades. People put up things in their stores saying, "Thank you, Dr. Salk." It really was seen as a miracle that this happened. That's a little bit different right now. I spend all my time trying to tell people, get the vaccine. It's good. It's good. It's good. We didn't have to do that with polio. It was a very different era where science was respected, and Jonas Salk was and is a hero. I have a behind me on my left, you can't see it. I have a Time magazine cover of Jonas Salk from polio. So I think this is a different type of thing than polio. And again, remember also, polio is affecting children. When things affect children, it gets prioritized very differently than when things affect 70-year-olds. I think I covered it. I think I answered most of that.
Yes, you did. Thank you. All right. The next question is that how will the technologies slash strategies developed during this current pandemic shape our future response to future diseases?
That's a great question. It's going to incredibly shape our response to future pandemics, future infectious disease emergencies, and medicine in general. We work very fast, and we developed multiple vaccines within a year. That had not been heard of before. It took 4 years for the fastest vaccine before this. And some of the technology used, you might have heard about you probably learned this in your biology class, messenger RNA or mRNA technology. That really excelled. It's not surprising to me that Pfizer and Moderna crossed the line first, because this technology allows you to rapidly make vaccine candidates. And even the Johnson & Johnson, the AstraZeneca vaccines, all of those use interesting new technologies, which are going to impact the way we think about infectious disease. There's many infectious diseases out there we don't build vaccines for because they're too hard or too expensive or nobody really is interested. But these new technologies make it much easier. So I think that's going to be better. Also, diagnostic technology. Many of you probably have been tested for COVID-19. That technology to test for things is dispersed everywhere. And it goes back to what I said earlier. We're going to be able to test for more viruses all the time when you go in for a cough or cold. Many hospitals and clinics invested in that technology. That's going to be different. We've also seen what we can do when you actually put your mind to it and try and solve a problem. So that's also going to open up new paths to think about how to fix infectious disease problems that have been long-standing, and not just from a technological perspective, but also a political perspective, because it's touched everybody's lives. And now people realize this is a priority. We can't just let public health dwindle and then expect to be able to handle a pandemic. So I think there's going to be a major revolution in technology that happens in the biotech sector because of COVID-19.
Thank you. You touched upon this one, but what effects of the pandemic have not been portrayed as much in the media or have been neglected, particularly how it's affected the poor and marginalized? And then also leading on after that, what do you think will be the long-term effects of COVID-19 socially, economically, and otherwise?
So I think that right now, I think the media has been covering all out of this, but what was happening early on is that people didn't a point that I want to make is that to be able to social distance, that's a luxury. Not everybody can do that. If you are an essential worker, not just a healthcare worker, but if you work in a grocery store, if you don't have savings, that you have to go out and this is especially true not in the United States, but in other parts of the world. If people don't go out and work, they may not be able to eat that day. Those people are not going to be able to social distance. And that, I think, was something that wasn't thought about that much. They just assumed that everybody would be able to social distance. In some countries, it's just not possible. And even some parts of the United States, it's not possible, because if you don't have the ability to feed yourself, you're going to die from something else. If you can't, you can't that's that whole idea of the long-term versus short run. It has to be sustainable for a person. And I think that was something that wasn't really talked about. So if you look at places in New York City that got hit hard, the unfortunately named Corona district of the Bronx, that area, I think Queens, or I think it's in Queens or the Bronx, that area got hit hard, and many of those people could not social distance. They lived in multi-generational family homes. They all worked. That wasn't going to be something that was sustainable for them. So I think that's really important to remember, is that when you have an infectious disease outbreak, it almost invariably will hit people that are in the that have less economic means more than those who have higher economic means. And you have to think about a solution that works for everybody. And I think that wasn't something that was really talked about. It became something that everybody thought you needed to do all this social distancing, stay home, but not everybody can do that. And I think that wasn't reflected. And people in the end, they didn't realize, that the economy, they kept saying economy versus people's lives, not realizing the economy is people's lives. Because if you're not productive, if you can't be productive, you can't earn your living, which you use to buy things that you need to live. to eat, to be cleaned, all that sanitation. I think some people kind of didn't realize that, you can't, production is life. If you stop production, you will eventually stop life. And I think that was something that didn't happen, that wasn't well characterized early on in the pandemic. I think it's getting better now. The press are starting to realize this. The other question, I think I answered a lot about the economics and all of that. So I'll kind of take another question instead of, because I covered that in the talk.
Yes, absolutely. So this one comes from one of our students, and he asks, how do you propose we could make hospitalization expandable? And do you think that there are other elements of the health infrastructure that could be improved to decrease the severity of future diseases and pandemics?
So how can we make hospitals more expandable? It's hard. Imagine in China, they need to build a new hospital. They built one like in 2 weeks. Imagine if you tried to do that in New Jersey. How many little township supervisors would you have to bribe? How many zoning board hearings would you have to go to? How many environmental impact statements? It's not easy to do that. And I'm not being, I know you're laughing, but I'm not being, I mean, it's true. You cannot build if you wanted to build a hospital, so many people would object to doing that. With a hospital, so you also have something called certificate of need in some states. So that means you have a hospital and you've got like an empty wing that you're not using. And you say, let's turn that into an ICU. Let's put 5 ICU beds in there. You have to then tell the state, well, we need those ICU beds. And who gets to object? Your competitors. Your competitors can tell the government, no, don't license those beds because they don't need them. We don't need those ICU beds. So states that had these certificate of need laws made it very hard to expand. So we have to be flexible when it comes to pandemics and get rid of these types of crazy laws and crazy bureaucracy that makes it impossible to expand hospital capacity. We also, if you're a doctor that I'm licensed in Pennsylvania, it's hard for me to work in New Jersey. I've got to fill out all this paperwork, pay a lot of money. That's hard to do, to move people from one part of the country to another. We need to have licensure recognition across state lines. There are some states that do that, mostly in the Midwest, rural states like North Dakota, South Dakota, Idaho, those places. But New York, New Jersey, Massachusetts, all those medical boards, they love the fees that they get from everybody, and they want to make it hard for you to get a license in another state. So that needs to go away. We have to get better. And the other point I would say is, investing in primary care would also be important as well. If you have, for other pandemics, for other health needs, if you've got a healthier population overall, the pandemic, you're going to be much more resilient to it. The fact that most Americans are overweight, obesity is a major problem here, hypertension, diabetes, that's kindling for a virus like COVID-19. That if you've got a population like that, this virus is going to find lots of people that it can land in the hospital, versus places like places where you don't have that high levels of obesity, much different. So I do think investing in primary care to get these chronic conditions under control would make us more resilient. And this is a hard problem to solve, because we kind of have a mongrel mix in our health, with our health system. It's like the worst of both worlds, basically. We don't have everything from the free market side, and we don't have everything, and we have kind of this mix that makes it much harder to actually navigate, because so this is a larger scale discussion, but in general, those are some of the few things that I would pick on: the certificate of need laws, being flexible with hospital building, and licensure portability across states.
Absolutely. This one comes from another student. He asks, do you think this vaccine will have to be taken as one of the vaccine requirements for children as they grow? Or will it become something yearly, like the flu vaccine, so on and so forth?
So I don't think it's going to be a requirement for children for some time, because right now it's only available as an emergency use product. We're still waiting for clinical trials on children that are younger than the age 16. So I think it's going to be some time before this becomes something that's required in schools, that schools say you need to have this to attend, the way they do with the measles vaccine, for example. But it could come up down the line. I don't think but not probably for the next 2 years, I would think. When it comes to, do we need to do this annually? I don't think we know the answer to that yet. We have to follow people who got vaccinated and see, do they get reinfected? Are those reinfections severe? Are they contagious again? To decide whether it's going to be a yearly shot, or every 2 years, or maybe every 5 years like tetanus, or every 10 years like tetanus, or something in between. We have to do those studies to figure it out. There are some mutations that are occurring. I touched on the variants before. I don't know that we've crossed the threshold that we need to update the vaccines yet. Companies are studying it, but we haven't seen the variants infect a vaccinated person and cause severe disease, land them in the hospital. And to me, that's the threshold. Because if our vaccines still work on the variants in terms of preventing them from making you really badly sick, I don't think we necessarily need to update the vaccines. But if they do make you sick again, if you get a vaccine and you get the South African variant and you land in the hospital, yes, I think that's a threshold, but we're not there yet. So stay tuned for that.
All right. And unless Ms. Friedlander has another idea, then I will say this will be the last question, potentially. So this one comes from a senior, and it goes, how confident are you in the long-term safety of the vaccine given its rapid development?
I'm fairly confident in its long-term safety. You have to remember that when we talk about the rapid development, what actually was rapid was getting a vaccine into clinical trials. It wasn't the phase 1 or phase 2 or phase 3 clinical trials. All that safety studies, no corners were cut there. What made it faster was they were using new technologies that weren't really available a decade ago. So we've got good data from the phase 1, 2, and 3 on the safety. That's, as the questioner asked, that is short term. We do follow people after they've been vaccinated for some time. And that happens with all of our vaccines. After things are licensed, we do what are called post-marketing studies. So we're still following people for the Gardasil vaccine against HPV. So we do look to see if there are any safety signals. I do think that this technology, because mRNA vaccines are so interesting and the molecule kind of degrades really quickly, I don't expect we're going to see a long-term safety signal. I think it's important that we do those studies and think about this and make sure that nothing shows up, but I'm pretty confident that's not going to happen. And remember, like I said earlier, every vaccine is a risk-benefit calculation. We don't have the luxury when you have a pandemic that's killing 1,000 people a day in the United States, that's killed over 500,000 people, to say, we can let's approve this vaccine 5 years from now when we have 5-year safety data. That's just not feasible. That's just not a rational way to approach this, because the risk benefit ratio favors this vaccine because it saves lives. And the long-term consequences, if there are any, I don't suspect there will be, are going to pale in comparison to what this pandemic did. And I think that's the case with any type of vaccination. When you're in the midst of a pandemic, the risk benefit ratio is often going to favor the vaccine and not waiting, because the longer you wait, the more people will die.
All right. And actually, there's one more that I thought was really good, which is why do you think virus cases are still increasing in northern New Jersey when the result of the country sees cases decreasing?
I think so. A couple of things. I would not just look at week-to-week data. Make sure it's at least 2 weeks, because a week doesn't make a trend. But yes, there are some places where you might see cases going up a little bit. New York, New Jersey are on people's radars, also Michigan. And it might be the fact, that people are tired of the pandemic, that they're starting to see things get back to their normal lives. You have indoor dining open in both places. You've got people interacting with each other. You've got schools open. You've got people just getting back to some semblance of normal life. And with a virus like this, any social interaction is going to increase cases. But again, remember what I said earlier. We're going to have to stop thinking about case numbers, because this isn't going anywhere. We have to look at hospitalization numbers. We're going to see cases increase, but you're going to see them decouple or separate from hospitalizations. So we're going to say, yes, they're cases, and we got to be careful about that. But this is a different type of disease now because our vulnerable populations have been vaccinated. So it's not going to land people in the hospital like it did before. It's not going to kill people. It's not going to threaten hospital capacity. But it likely has to do with increasing social interaction. New York does have a variant that was identified in Washington Heights. That was something that people think may be more contagious. We're still waiting to see whether that's the case, but it's likely just the fact that people are socially interacting more. And it's not surprising.
All right. Well, that concludes the questions that I have. Again, I want to say thank you for answering the questions and just for being here this morning and sharing all that information with us.
Sure. Thank you. Anytime. And thank you again for the opportunity.
Thank you, Dr. Adalja. I actually do want to nerd out a bit and ask one more question just for me. And one of the things you mentioned in your talk was how with some previous sort of pandemics or health crises, you would see a sort of increase in healthcare funding for that moment, and then it would sort of trickle away in the aftermath. Do you think that this pandemic might really serve as a final wake-up call for or to systematically address healthcare nationally and globally?
I do think this pandemic is a major wake-up call because many of us thinking we were talking to deaf ears. Everybody kept saying, oh, that's like a 1% chance that's going to happen. And now that it happened and we saw how bad it was and how much could have been prevented, I do think there is an opportunity to actually fix this and come up with a sustainable approach to thinking about public health, to thinking about infectious disease preparedness. So yes, I do. That's why I said, this is a time to call your Congress people, to call your state representatives and all your political representatives and say, this is something that we prioritize, that this is important, fix it. Because we can't let this happen again, and it is your fault, basically is what I would say.
Thank you, Dr. Adalja, and thank you for being with us today. Thank you for your wonderful and really informative and thought-provoking presentation. I think you really provided us with a sort of comprehensive historical context for the current pandemic, and also a very sort of nuanced and informative understanding of what this virus, what our healthcare system can look like going forwards. I speak for all of us when I say we really appreciate you taking the time to share your knowledge with us and to answer our questions. And I also want to thank Ms. Friedlander, as always, for helping us out with the webinar. And thank you for Aaron for doing a terrific job on facilitating our Q&A. And thank you for all of you guys, our students, faculty, and staff, for attending today, and especially for those on our Arrupe Planning Committee, who really put in a lot of hard work to prepare this year's series. So thank you all for your attention. Thank you again, Dr. Adalja, and I hope you all have a wonderful day. Thank you.